Right, good evening. It's great to see all my good friends here and to be doing another evening of just discussion. Now, I always thought vertical dimension and vertical improvement, vertical regeneration would be a topic that would get everyone going. And so, it's nice to have a little bit of a debate on this matter, because it's something you get asked all the time, but it's actually something that is actually, very difficult, yet very easy. It's nice to have this panel again. Dom, my old friend from Leeds, and Stuart, who's sitting a couple of rooms away, works here at the practice. He's going to moderate the evening. And, of course, Riz. And what Riz is doing is just being continually impressing a lot of people and myself with Nasalis and Zygomatic. I mean, you've been really taking on some interesting cases and getting great results. So it'll be interesting. So we've got a nice cross-section, a nice panel, and we'll have a whole lot of questions. And we will show some cases as well. Otherwise, it just becomes a bit dull with people just listening to four people talking. And we always like to sort of see, because this is a job where you learn from what you're seeing as well as what people are saying. Right. So, Stuart, what's the first question for us this evening?
So let's roll on with the slides, and we'll start with how effective is Ethos on vertical augmentation, which is one we always get asked. And Riz, Dominic, do either of you want to step in and start with one of those?
Well, I'm happy to step in there and say, I think the first thing to say is it's like any attempt to replace nature, and it's a combination of two or three different things. The first one is you've got to have the right case. So you've got to have meticulous planning and make sure that it's the right patient to have this type of treatment. Secondly, you've got to make sure that you are pragmatic with the patient, so you don't overpromise and underdeliver. If anything, you underpromise, and then you've got an opportunity to overdeliver. And then thirdly, I think it's effective, but it's effective with caveats. And for me, in my own practice, the caveats are that I can predictably get a couple of millimeters of vertical augmentation with Ethos. So if I'm looking to get more than that, then it's unpredictable in my hands. But if I'm looking for a couple of millimeters of vertical augmentation, it's fairly predictable for me to get that. So I think the second thing to say is it depends what you really mean by vertical augmentation. If you're looking at a circumferential defect where you're placing your implant in the correct position, absolutely, and often this would be supracrestular, because you're actually placing your implant where it needs to be, and you're basically using your Ethos circumferentially around the implant. Then again, I'd say it's a couple of millimeters max for me. So that's my kind of position on that. What do you think, Riz?
So I agree with you there. I think there's a limit on how much you can augment, and I think you're absolutely right. When it comes to these sort of cases, it depends on the anatomy. So if you have bony peaks on either side, and I think this is the thing that if you're going to be grafting vertically, when you talk about true augmentation, where there's no peaks on either side, then it's difficult to augment. If you've got peaks on either side and you have a dip that you're placing the implant up to the adjacent bony walls, then I think it's very predictable. But again, it's only 3 millimeters. I think where you're trying to push it is where you're doing augmentation across the whole ridge. So, for example, in full arches, in my case, I don't mind placing the implants where a few threads are showing, maybe a millimeter or two, and then augmenting onto that. Anything more than that, then I think we have to think about how that's going to work. And the other thing I want to point out is that what's very important to me, and I think with any sort of grafting, is the actual suturing and the actual closure of the soft tissues. So with any sort of case, if you're going to get a non-passive closure of the soft tissues, regardless of what bone substitute you're going to be using, you're going to lose a lot of that bone. So whether it's going to be a lingual release or a buccal release, I think that's very important to learn how to do that before going on to these augmentation cases.
Yeah. Just to go on from what Riz has just said as well, I'm sorry for butting in, but I think that fitting in with that tension-free passive closure, I think you've also got to look at especially when you are doing a full ridge or particularly in a case where you're not placing implants at the same time. So for example, where you're trying to vertically augment prior to implant placement, you've got to think very carefully about stabilization of this vertical element of the graft. And if your patient is relying on a denture, it's very difficult indeed to achieve both passive closure and something that's going to be stable during mastication for that period of time. So one of the advantages, I think, of immediate, cross arch bracing and placing implants at the same time as augmentation is that you can achieve some form of provisional solution that provides protection for the graft as well. I think you'd agree with that.
Yeah, definitely. I think this is why, obviously most of my work is full arch and immediate load. So for me, there is no danger of any sort of prosthesis pushing onto the soft tissue. No. So once we've augmented and sutured, we have a healthy band of soft tissue, which then doesn't get compressed, and then we can always go to the second prosthesis once it's all.
Yeah. Coming on to the soft tissue, Riz, when you've got that full arch and you've got a huge flap across the entirety of the maxilla or the mandible, you've got one of the benefits is you bring in that soft tissue across, and no matter how tight you go for that primary closure, because it's such a big flap, you really don't have any tension in your closure. No, that's one thing I found going from full arch to placing single implants. Another reason to underlay down your ethos is if you place too much ethos and you've got too much ethos underneath your flap, you're never going to get a nice closure. You've got too much material and not enough space to close.
Well, the problem is, with single teeth, you have a lot of this soft tissue shrinkage, so you have to think about how you're going to release that soft tissue. You're absolutely right. On full arch cases where we're going to be stripping back a lot of the periosteum, we have that release built in anyway. And then it's up to us to decide how much soft tissue we want. So we have the luxury of doing that. Not always the case, but a lot of the cases. The other thing is when we have a resorbent mandible, for example, we can place the implants and we can still have an area that needs to be augmented, even though the soft tissue isn't as good because we can't cut the soft tissue because we don't have too much keratin tissue. And I think keeping that is very important as well. So we don't want the movement of the muscle around this graft area either. So we can either release the soft tissue around those areas, and that includes frenums. So, doing a frenectomy around those parts as well. That's important with soft tissue augmentation.
Yeah.
So coming back to that question that we started on, how effective is ethos on vertical augmentation? I think we all sort of share that opinion that working within the sort of realms of bony physiology and what we'd expect for bony healing, it can work very well to give us an advantage in a slightly compromised site, but we can't expect many millimeters from it. 3 or 4 millimeters maybe, but not lots of.
Yeah, and I think
too much.
I think the second thing you've got to think about is the other aspect of vertical augmentation. So for me, it's creating vertical bone to make sure my implant is fully, the bone to implant contact is appropriate. But secondly, I think it's improving and enhancing the soft tissue vertical component. And I think that's just as important in some ways, that you actually achieve a thicker, more predictably resilient zone of keratinized tissue. And so the second way that I feel ethos is very appropriate for vertical augmentation is if you expand the definition of augmentation to include the whole envelope of bone and soft tissue. And so it fits in with my protocol, which often involves secondary intention healing on the top of the ridge to create an enhanced band of keratinized tissue that I count as part of the vertical augmentation of the case, if you see what I mean.
I agree with that. I think the reaction is just by chance. It's not what the primary reason for ethos was, but as we're doing more and more of it, we're seeing that when the patient's coming back, the area that we've grafted, the soft tissue tends to be thicker more keratinized in nature, which helps around the implants. And I don't know, Don, I've seen you do a lot of these immediate cases, and whether that's immediate load or whether that's putting a healing button on, putting the Ethos around and suturing up like secondary intention healing. That band of keratinized tissue, once you take the healing abutment off, you can see that band looks really, really thick, which, as you know, stabilizes the implant as well and the prosthesis.
That's correct.
Yeah. Having used these materials and techniques for about 20 years, the interesting thing is the long term and how it continues to improve. And even now, when I'm looking at 7-8 year Ethos cases, I'm often shocked when they come in. Unfortunately, when you're doing, as you travel, you don't get to see the cases as much as you'd like to. And it's the same when you're getting referrals in. They go off and you don't see them unless porcelain's chipped or something. And then you're actually surprised that you've actually gained another 2 millimeters of vertical in function. And this is a sort of a weird phenomenon where we come from a big talk that you're going to lose half a millimeter and a millimeter, a third of a millimeter every year afterwards. And so it goes back to the whole thing of regenerative. And this is often when I sort of see, traveling and lecturing and see guys doing big verticals. And then they turn around and they say, look at the bone quality. But I'm like, how can you assess the bone quality by just having a look at a picture of bone? With scientists, you have to actually look at it scientifically. In other words, take a core sample. And this is what led to this bit of a fallout with Joseph Kahn, I think a year ago, where he was saying, yes, he was doing big grafts and using a lot of foreign material, and that there was issues 4, 5, 6 years down the line. And that's why success sometimes is also assessed in quality, not merely quantity. And, this is quite a difficult thing to get across. But, I think what we would be doing in the future is doing different techniques and trying to get a higher quality of bone. And you see that with a lot of people when they're changing their mixes. So they're using more demineralized allograft and use less xenograft. You see a lot of that when they're trying to build up ridges, because they understand what they're trying to do is improve the quality of the bone. That's the thing.
It's very interesting you say that, Peter, because one of the things I like when I see, when I use Ethos for crestal lifts, and this fits very nicely with what you've said about the quality of the bone rather than the quantity. For me, personally, I like nothing less than looking at an old sinus lift where you've got a big hunk of cow sitting there that hasn't physiologically adapted to loading over the years whatsoever. So you've just got this lump. When you see a crestal lift with Ethos, what I'm tending to find is that you're seeing only the amount of bone that you need. So the implant's loading influences the amount of bone that's there. And then you often see that cortical plate develop. And to me, that's quite a good indicator that what we've ended up with is quality host bone that's in function, and it's not there for no reason.
And 2 points there. One is the fact that when we're doing a vertical augmentation, sometimes people think that once you've done a vertical augmentation, that's it, and they put the implant into that site, whether it's going to be a delayed or immediate. Now, I always find that, I always say to people who are working with me that with Ethos, you can go back, and sometimes you have to go back and augment further. It's not just a one-time augmentation. And that goes to the surgeon and the patient, because although you're trying to achieve this wonderful bone, you might get 3/4 of the way there. The second graft then will actually enhance that site even further. And the other thing with the crestal lift that you were saying, that one thing about Ethos is very forgiving, which I think is very important. Unlike having something that's going to be bony and sharp and can cause tearing off the membrane, Ethos is a lot more forgiving. And if there is a perforation, there's no consequences to that perforation, because then you can go back in later on, or you can repair that, you can do whatever. But unfortunately, with particular bone, the bone into the antrum, you're going to cause all sorts of problems. So you have to be very careful. Ethos is better handling with that. But again, that goes back to another thing, which is about the mix, whether you do a dry mix or a wet mix. Now, vertical augmentation on a wet mix, and then people go back and say, well, there's not much bone there. Well, obviously, there's not going to be, people will run away. So you have to know how to handle the material for different parts.
Radiographs only show what is mineralized, and often there's a lot more bone. And this is why CBCTs often don't show us an exact true story. And so often at 8 weeks or 10 weeks, people less, 6, 8 weeks, people think, oh, they're losing the graft. They're not, just going through a phase of low mineralization. And this is why we're surprised when we leave it for longer. It does tend to get better and better, the cases, and I could show a whole lot of those.
I agree, because people do worry, especially when I'm traveling around. I get X-rays being sent to me saying it looks like the implant's failing because you've put ethos around it. However, you're right. It's that healing process of the bone that takes a while for it to then show up on the radiograph.
Yeah, I mean, I put a case up on case studies the other day, which really showed it. It looked like I'd lost the entire graft. And 6 months on and a year on, the amount of bone was absolutely stunning. It was sort of 3-4 millimeters vertical growth, and it was just an incredible case. Often I get accused now of placing implants too deep, and I'm from the old school where everything used to be super crestal. And it's not that I put them there, it's just that they become there by a vertical improvement. And this whole process does take longer because it's called healing. Yes, I can show an osteoid buccal plate as little as 6 weeks, but for it to really mineralize, it has to be in function and then turn over, and that's when the cases look better.
That's correct.
What's the next question, Stuart? But I think all three were the same, the first three.
Yes. So if we turn over, can a fully resorbing graft material such as Ethos be useful for vertical augmentation? I've tried several times to do vertical augmentation, but the Ethos bone graft seems to resorb. Do you have any tips to improve success? I suppose, this comes back to what we were talking about working within the physiological bone sort of expectations for healing. If you had a dentulous mandible behind the premolars, and you thought you could raise that mandible by 2 or 3 millimeters by laying on some Ethos, you might be able to get a small increase in bony height. But if you've got nothing to support your graft when you're putting it down, you're not going to maintain that bone. One of the things that Pete is always doing and always telling me to do is place my implant at the same time as grafting, because your implant is supporting your graft. And if you need anything else as well, you've got the little PDS suture technique. So there's a technique.
Your third method there is to think about a titanium reinforced non-resorbable membrane, or something that Stavros is doing, which is the little bone plates made out of titanium. Anything to give you that rigid structure that you can then place your Ethos beneath and achieve some level of protection. I think going to that second part of the question, it's down to what we said before. It's tension-free closure, but it's also achieving stability of the graft material, and also not being concerned by the fact that you're going to have your calcium sulfate binder disappearing over time, and you're going to have a difference in appearance of your radiograph, as we just discussed. In the 2 weeks, 4 weeks, 6 weeks, 8 weeks, 10 weeks, it's going to look different. You're going to look as if the graft's gone. And then, as Pete said, over time, as the bone remineralizes and becomes adapted to function, you'll find that you've got, in most cases, you've got a great result, as long as you've been careful with your selection and you've been meticulous with your surgery as well. And going back to what you've said, Stuart, staying with the physiological parameters of the bone that you're working with, not being silly.
Yeah, this is a critical thing. is we're doing regeneration. You look at our receptionist case that I tunneled 4 years ago, how much better it's got with time. And I mean, it's extraordinary, you know, being able to have a look at it every couple of months, which you don't do with normal patients. And it seems to have got so much better. I think maybe what we should do is if we, Dom, do you have some cases you want to share?
No, my purpose tonight, guys, was to become a bit of a rabble rouser and criticise all your cases as much as I possibly could. So.
Right, because I know Rizzy's got one. I tell you what, I'll just go over and I'll just take it at a moment just to go to like just the usual basic introduction and explain the difficulties and the benefits. So I'll just show my screen for a few minutes and we will go from.
Yeah, it is now.
Okay, cool. You know, I just wanted to go through it because, as we were saying, it's this understanding of the basic surgery, bone biology, and this is another thing is that occasionally I hear the material did not make bone. Well, the material doesn't make the bone; the body does. The material can only help the body. So it's a simple thing. As for not using membranes, this is a recent sort of study we've done, and it shows that if you use a membrane, which is good for stabilizing the graft, it actually leads to 50% less blood vessels in the new bone, which, you know, can impede healing. Because whenever I look at this, you know, we've always got to remember that once we're using a xenograft or big blocks, it makes it easier to build the wall. It's much easier to build a wall with bricks. But the host bone is only the cement. And that's a problem when we look at things histologically, histomorphometrically. When we look at this as a comparative study, ours was at 10 weeks, this is at 6 months using bovine bone. And when you look at it on histomorphometric, at 6 months, the red is the host bone, whereas at 10 weeks, we've already got this. So, yes, all you're doing by using these bricks, you're filling the hole better, but you're actually creating less host bone, therefore lower bone quality. And this is all in all the research where we lead to a lot less bone. And with bone to implant contact, once we have these residual particles, it can have an impact on the case, especially over a longer period of time, because we want solid bone. This is the key. And the only way we can tell that is by histology. Yeah, so Dom, I was going to go through this case because this is sort of a little bit of vertical, but again, as Riz said, this is easily done because it's supported by two adjacent teeth. But what we have here is lost both the palatal over here and the buccal plates. And so it makes quite a difficult case to restore in some ways. But the other thing is this bone on the adjacent tooth. And this has been lost as well. Now we need to restore this bone so that we can keep the papillae long term. So, and as you can see, that's the buccal plate, palatal plate. We'll talk about this afterwards. What would you do on this side? How would you clean it? And when we've grafted, we've placed the implant into the wet mix. You can see the implant into the host bone is only up to about that thread. So we're looking at, 4 or 5 millimeters vertical. This is the buccal plate here. So, but I've actually placed the implant 2 millimeters subcrestally because that's where I'm going to regenerate the crest to, or where the host is. So there it is with the dryer mix over it. Future closed. Yes, Dom, as you say, by getting tension free, if we leave the space on the palatal side, we get secondary intention. And here it is at 10 weeks. Now, I'm not raising a flap because you can see the bone on this side. We now want to keep the papilla to keep the blood supply to the bone. And you can see the dramatic improvement on both the adjacent teeth of new bone. Look how far this, has extended on the adjacent. I'm not going to show it, but Rob Aurade did an amazing case. Now I always cover the distances as well. And we just done a second layer. And as Riz was saying, this is a second layer just to improve the soft tissue in a way. So there's the healing cap, wider healing cap, restored. And you can see we've done no soft tissue grafting. The host does the soft tissue. And there it is from the start point to 1 year later. And the interesting thing, not looking at the x-rays where we can see grafted 10 weeks, gap, and loaded. But when we look at scans at 6 months, you can see that's where the palatal plate was, that's where the buccal plate, and you can see the vertical improvement there is probably 6-7 millimeters. So you can, in the right situations. But the most interesting picture here, the one on the adjacent tooth, and you can see how the host bone is fully regenerated up on that tooth. You know, the same thing when we're doing you can see on socket grafting here, and you can see how the vertical allows us to use Versa. And you can see the quality of bone at 10 weeks. There was no bone here. If we go back, if we look there, and that's at 10 weeks. And this is the key to it, is very high quality post-regenerated bone, just using Versa. I know they're not gold, Dom. Place and restore. And this is an ex-wife of a dentist, and he said, don't mess this one up. It may cost me. So when we look at scans, we can get this vertical improvement in the right situations. You can see missing the buccal plate and the palatal. And here it is at 9 months. So we've taken this case like here where there's just nothing, and here it is 3 years later. And so, you know, in the right situations, you can do it. Yeah, this is an old one of Ludwig. And you can see this is at 10 weeks. You can see the vertical improvement and the horizontal improvement plus improvement of the keratinized tissue, all in one go, all in one surgery. You know, so the hard tissue, that was where they were placed. Okay, you can see this was into the socket. This is a narrow ridge. This is 10 weeks later, and you can see there's a millimeter or two vertical and 2 millimeters horizontal. And this has helped improve the soft tissue from before to afterwards without doing any soft tissue work. Finally, I just want to show vertical. This is without, this is obviously a edentulous posterior ridge. This is a low 7 I'm doing here. And you can see we often get this when we've taken out the implant. So I've placed the implant, but I haven't left this one high because it's more the design of any ridge. And I've just grafted over the top. Here it is at 10 weeks. I got access using Rambo, and here it is 2 years. Now, why should we bother about this? Well, the key with this is it also increases the keratinized and attached keratinized tissue 2 years on. So, you know, I feel that this vertical improvement is important. Yes, it's much easier in these situations, but when we look at it here, it looks like we're losing the tissue. Look at the vertical improvement at 2 years. And this is what gives you this nice stability of tissues. As Riz was saying, it's about tissues as well. So let's take it back to the discussion now.
If you don't mind, Peter, just to go through a few of those cases, to talk to you quickly about them. One of the things that I totally agree with is that you're looking at your bony crests and you're using that for your basis of your Ethos build. And you're not worrying too much about the fact that you haven't got a buccal plate, or that perhaps even your plate might diminish as well. What I find very interesting is going back to talking about the x-rays where you start worrying a few weeks after placement or that you're losing bone. What I tend to find once my implants are in function is that I start seeing something called round the corner. This is my own term for it. And this is where you see with platform shift on your implants that you see your bones going around the corner of the implant. And you see it time and time again. And even though at one point early on when perhaps your implant's just transmucosal with a healing abutment, you might think, oh, what's going on there on the crest? And you do see this time and time again. Once you got it in function, you see this bone around the corner. And that to me is a sign of great long-term stability. I don't know if any of you other guys see that. Do you I know you tend to place quite, you place subcrestal, don't you, when you're doing, I know you're mainly doing full arch, but.
Yeah, no, even single cases, I place subcrestal. I think I've gone away many years ago from placing at crestal. I always go subcrestal by a millimetre or two, especially with the new implants, for example, the inverting. As done,
I think some of this is implant design. I've got other cases, 6 years, where I show this, and there's a lot of factors for this, but I think so much has changed in implant dentistry. I just watch what you're doing all the time, Riz, and the progress is just huge. It wasn't long ago Nasalis was unheard of or experimental. Now it's a really fundamental part of.
Well, definitely. I mean, for my cases, I mean, one thing I'll say was about the inverter where we're placing it subcrestal. The main thing is that if we've got bone and we've got soft tissue support, it doesn't really matter. Gone are the days where we say we have to be at crestal level. Now, we're not going ridiculously, but we are going deeper than we were before. However, as long as it's supported, that's important because you're going to maintain the soft tissue. Hence the reason why Ethos, when you get that bony build-up above the implant, that's going to support the soft tissue for long-term results aesthetically. For Nasalis, for example, Nasalis plays a key role in my full arch cases, especially in younger patients. The problem is everybody's jumping on board going, let's go straight to zygomas or these full arch phrases. Everybody wants to do it. The problem is the more experience you get, the less you're doing, simply because you don't think it's the right treatment for the patient at that time. Now, for me, a young patient isn't necessarily going to be a zygoma patient. I've got to future-proof. Hence the reason why I want to have an implant that can be used for a long period of time, and B, I want bone around the implant. So for me, raising the small window where I see the sinus a little bit out of the way, so placing it into the nasal bone, I can then add Ethos as a graft. And as I look at the x-rays, I can see bone growing around that nasal implant, so it becomes a solid implant. Now, if 15, 20 years down the line, the patient needs to go to a zygoma, they've got that option available later on. I think it should be all these things incorporate together and make everything work.
Yeah, Nasalis is a really good get out from actually applying the full zygoma at too young an age, as you said. I mean, obviously on the other WhatsApp site we're on, it's so extraordinary that the level of cognition on them and the debate on that age and zygoma was quite interesting.
I think it's to do with Peter. I think it's not just, even if you are placing the zygoma implant, I think especially when people start off, they're placing it in the middle of the zygoma. Now the problem with that is, if then the patient needs a quad zygoma or an implant fails, the zygoma fails, where do you go from there? So I think the example that Nasalis says on the patient, but when you do place it, you play it lower down so you have room to place a second zygoma. For example, full arch case today that I was doing, that's the reason I joined a little bit later, was a full arch case in a younger sort of patient, but we used a combination of max implants and the molar size plus Ethos, so we're doing internal lifts and placing implant. So now we've placed 5 implants today, full arch case, but it was a combination of using Ethos and max implants, which for me, gave a really good spread of implants, and now the patient's going to be fully loaded and there shouldn't be an issue.
I mean, that excites me quite a lot. Sorry, just to say very briefly that the fact you're using max implants, then you're getting that incredible surface area of that implant, and yet it's a shorter implant. So therefore, you're in some ways you're using your Ethos for your crestal lift, but you're still getting that massive bone to implant. Great idea. Yeah,
and we were doing Ethos was around the actual sockets that were left. We were placing Ethos, so I always on my full arch cases now, which I never used to before. But more and more now, even when I'm doing zygoma or full arches, all on fours, the sockets that are remaining on future and then Ethos. I'm going to go back in. If there's ever a problem, we can always then use other sites that was damaged at the time. But now, later on in the future, they can always be used to place more implant.
So there seem to be 2 things there is. Now, one thing is the Ethos is allowing to use sort of contingency graft, i.e. develop sites for future use. And the second point, it's allowing you to be slightly less invasive by going for something like the nasalis rather than going straight up to a zygoma.
Yeah, absolutely. I mean, we've got a few options now available. You're right, you're future-proofing the patient. The option that we have available with nasalis, coax implants means that we can then do a complex surgery later on for the patients. So I think there's a number of things that you have to do. A lot of people are saying, well, you need a lot of ethos. It doesn't matter. The patients are coming in. And for me, it's not about how many vials I'm going to be using, how many syringes. It's about making sure my patient is then future-proofed. And that gives me a great way of doing that. And when I go back in, by chance, as Peter says, I don't normally go and see the patients again. But when I do go past the surgery working and somebody takes the bridge off and I have a look at the soft tissue underneath, it's incredible. Got really nice band of keratinized tissue around either the zygoma or the abutments. Now with zygomas, I always, even if I've got generally good bone, I always put ethos around it, because that for me is the area that you're going to have a problem with the zygoma, is that communication. Because if that bone goes, then you're going to end up with problems later on.
Yeah, and I think just going to the access issue as well, when you're using nasalis and you've talked about using max implants, you've got cleansability of your prosthesis. I think one of the issues perhaps with pterygoid implants that are also being used more and more can be that you end up with a very distal access on your implant and it's behind the prosthesis. And to me, that becomes a challenging cleansability issue for your patient.
For me, on that point, I mean, on the pterygoid point, it comes down to the design of the prosthesis.
Yeah.
Having seen quite a few pterygoid connections, if you've got a well-designed prosthesis with a slim pterygoid connection, the pterygoid tissue just seems to respond incredibly well.
Yeah.
I've very, very rarely seen it inflamed. But it comes down to having a well-designed prosthesis with a slim connection.
That's it, exactly. If it's polished, I've seen very good connections, but at the same time, I've seen some very poor ones at the zone. So it's about the whole shebang here. It's about working closely with your technician in the pre-planning to ensure that your case is in the round, if you see what I mean. Not just
This is interesting for me. It's interesting hearing from Riz about using the ethos in the full arch cases, because I've come from a purely full arch background where we were doing FP3 prosthetics and also then worked with Peter on a sort of single tooth type approach where we're building up in and around teeth. So sort of merging the two. And I mean, we've used ethos in full arch cases in the past, but I hadn't used them as much as I had used them with Peter here. But developing the sites and developing the soft tissue and remembering that the ethos is developing your bone, which is your mineralized connective tissue, which responds to stress and strain. So you've got your implants in ethos, which is a mineralized connective tissue because it's turned into host bone. That's why we're seeing those better sites in the sinus 2-3 years down the line, or some of those cases that Peter showed in the mandible where the bone's increased in height 2 or 3 years later. It's turned over into host bone, and it's just keeps turning over.
Well, funny, Stuart, you're going from, as you said, going from an FP3, which is what I do a lot of, because obviously they're quite extreme cases. However, some of the cases that come along are FP1. Now, to develop those sites with ethos, I think are really important. So that's what I'm doing. I'm doing a meat extraction place. We're trying to go for an FP1. The Pontic site, ethos is placed and then developed with the actual prosthesis, which gives you a really nice result.
Yeah, I was just saying that, Riz, it probably is quite an exciting thing in a way if you can actually make it FP1 for the patient and for yourself to, it's such a big stretch for a lot of people to go straight to FP3. If you can avoid it, I think that must be a real aim all the time.
Yeah, I think it was common back. I mean, I've been doing full arches for over 15 years, and we were just, we were taught by taking the teeth out and taking 3-4 millimeters of bone, if not more, and then doing an FP3 bridge. That was standard. But then when you come across the case, I had a case recently, which was only a 23-year-old patient who was injured at work and broke his back, went into a bit of depression, had to lose all his teeth. Now, the question then came in, do I go for an FP3 or do I try to do an FP1? Being only 23, where's he going to be in 15 years' time? So we went for an FP1 type bridge, and Ethos everywhere around all the sockets and placed the implants in where we thought was the right position. Now, the result so far has been beautiful, with soft tissue developing. We're in the first phase. But that to me is exciting, that we can now incorporate that side of it, as well as doing all the other techniques that we do.
Yeah, it's just sort of one step of the ladder at a time in life, rather than,
it's sort of the equivalent of a patient walking in who needs a small filling, and instead of giving them a crown, you're restoring something smaller. It's sort of triaging your approach and your restoration, and trying to keep them off that sort of life cycle of restoration, and try and keep them closer to where they are. So we're not removing too much.
No, well, the funny thing is, patients absolutely hate, if you're going to go from a fully dentate patient or give them a prosthesis, which is like a denture with 4 screw access holes, that's very difficult for a patient to transition to. Going from someone who's wearing a partial denture to having a fixed bridge is much easier, and they appreciate it much more. So again, it's a very gradual process to get to that point. And that's the thing you have to emphasize when you're doing full arches, is that you have to show them what the prosthesis is going to look like, show them pictures so they understand fully what they're getting involved. Because the last thing you want to do is when they fit the full arch and they look at it and go, well, I thought it was going to be different. Why is there plastic in my mouth? That's what they signed up for. However, they don't fully understand it.
Yeah, that's one of the...
Just a brief point there with regard to ridge preservation. I think when you're doing your full arch and you're obviously thinking about your FP1 res, and you're preserving these sites potentially for future use, I think I've really got to emphasise the need for careful degranulation of those sockets. From my own point of view, when I'm doing it, immediate load, single cases or smaller cases, degranulation of those sockets is so important. What isn't as important for me is ensuring that I've got Ethos packed tightly in the apical third of the sockets, because nature's very, very good at giving us bone back in those areas. So, I'm not overly worried about getting it tightly packed right to the base of the socket. But what I'm really worried about is making sure that I've got it there in the mid-third and the coronal portion of the socket. And then it's stable and it's going to be controlled in that region. Because, I'll just go re-emphasize that point again. Nature sorts out the apical third for you. You don't have to worry about that bit too much. The only reason you have to worry about it is if you leave a load of connective tissue or granulation tissue there, and then it's a problem. So it's
cleaning the socket is so important. Degranulation burst, because when you're putting Ethos into a socket that has granulation tissue, and people say, well, the graft doesn't work. Now, it's happened to me in 1 or 2 cases where I thought I got all the granulation tissue out. When you go back and have a look after a few weeks or a few months, that area that you socket preserved, if you're doing that, you see that the Ethos is separate from the actual granulation tissue because it's never had a chance to actually heal. So degranulation is very important. And the other thing is that sometimes when you're pushing Ethos into a socket, doing immediate extraction placement and you put the implant in, you can, when you're pushing it down, you actually end up with this stability that you get prime stability for a while, and then you lose all the stability simply because you push the Ethos down into the socket that you're drilling, where you've drilled the osteotomy site, and therefore the implant then is up against the Ethos, and then you don't get that true primary stability. So I like the idea of putting Ethos against the buccal wall, placing the implant in, and then packing Ethos around it, not just filling the whole socket.
And that fits in with another philosophy of mine, which is I'm happier to do that and use my implant to go through my final tranche of Ethos if I'm doing a crestal lift, because there's somewhere for the Ethos at the right mix to go. What you don't want is you don't want a perfectly intact socket with a fairly closely associated implant size going into that Ethos. And I noticed that, there's a couple of clinicians that I know who've done that and have regretted it. It's because they've created this incredibly condensed wall of Ethos against the socket. And you kind of lost the philosophy of Ethos right there. You've lost the biphasic calcium, tricalcium phosphate. You've squeezed all the calcium sulfate out of it. And you've basically created something where, as you've said, Riz, as the days and weeks go by, that ethos disappears and you end up losing the entire primary stability of your implant as well.
Yeah.
So I think it's technique sensitive, but I think the watchword has got to be just trying to reflect on the fact you need somewhere for the pressure to go. Don't just put it in and create a massive level of pressure, because that's not going to work.
That's exactly what. I mean, I've lost in my hands when I first started using Ethos. I lost stability of an implant, and then I went back in with my actual. I think I was placing a 4mm implant. You go back, you drop down a drill, and then you prep the site again to move the Ethos out of the way, and then put the implant in. You get primary stability, so it doesn't bottom out.
Yeah.
I think one of the things that I definitely underestimated when I was using Ethos was the variability that you can get out of a wet mix and a dryer mix. Yeah. And it wasn't until I've been using Ethos for about a year and a half, 2 years, that I was nursing or assisting with Pete. And he was like, okay, we're going to put a wet mix in here and then we're going to put a dry mix on the top. And I was like, what have we just done? But I need to learn how to use that, because we put the wet mix in first as a layer onto the bone, so that as your implant went in, it took a little bit of it with it. And then we did a dryer mix over the top of that coronal third. There's lots of little things like that that just help with making everything a bit more predictable.
Yeah. When you see Pete's cases and you see the master at work, you see he's been using it so long. And you see them place, as Riz said before, as he places that first tranche of Ethos in a wet mix against the palatal wall, and he places his implant in the correct 3D location. And then he places his second tranche of Ethos over the top, a dryer mix. It looks simple, and it isn't, but at the same time, it's very, very predictable. It just has a slight learning curve to it. And once you get through that little learning curve, it becomes very predictable at that point. That's the thing.
We were just looking at, I was showing Stuart a case just before, and it's the only, I've been using a Korean company brand for the last 3 years, and it's the only one that I've loaded, but it was into a massive cyst site, and I just don't think I cleaned it properly at the time. But it failed after about 4 months, and I then left it for 2 months, and I opened it, and how was the site? I mean, it was just the most incredible bony site. All the cyst had healed up. So, it does, and the result looks amazing. Now, when you look at it before and after, I've got this incredible keratinized tissue. It just looks like it's a tooth coming out. But he was a terrible healer and a heavy smoker. And he just wouldn't listen to a thing I said. All medical people were charlatans, just there to make money. And guess what? His implant fails. It was the first one in like a year and a half that I had fail. I mean, we've all had things fail, but it was just the wrong guy. Anyway, Stuart, what's the next question? Let's get on.
If we move on to the next slide. So, has this procedure been used in the reconstruction vertically in management of periodontal defects and around sites of peri-implantitis? What long-term stability studies have been completed in the management of these defects with Ethos?
Well, this is an interesting thing. I'll start off on this. We're doing a couple of studies with Zurich and I've been doing some perio recently, and getting you've seen them, Stuart, getting amazing results and saving teeth that I would have normally just put in the bin. And this is 4 or 5 years later, and so I am seeing a sort of a value and getting vertical improvement and taking grade, mobile teeth to not. It's not my area of interest because I like getting the forceps out and giving them my titanium route. So I do think there's something in, but again, with a lot of these things, it takes years to really come to any conclusive evidence. But what we're seeing at Zurich University is interesting, and also we're doing a study with Rome, and it'd be interesting to see what comes of it. But we're constantly seeing cases with periodontists now using it, getting things that they hadn't seen in the past. When it comes to peri-implantitis, the reason I never talk much about it is it's such a wild. I've had some amazing results, and then I've had some really disappointing results. And anything that's not predictable, I don't want to talk about, because once the bacteria get in there and you've got the wrong host response to bacteria, like this whole COVID thing, it's not that you're old that you're going to get a bad response to COVID. It's you've got a inflammatory response, poor response to inflammation. And I think that you try and fix those cases, and sometimes it's best to always just take it out, start again.
I mean, I totally agree there. I think the first thing I'd say is over the years, I've tried various techniques with peri-implantitis, this wide variety of different processes that are all under this envelope. And I suppose it's a case of, I think if you're going to treat these cases, you need to be very honest with yourself about the viability of the implant. Is it in the optimum location 3D? Is it salvageable? An implant that's 50% affected by peri-implantitis, it's coming out in my hands. I'm going to remove it. Explantation of it is, for me, far more predictable than trying heroics with something like that. But if you're going to do a treatment of peri-implantitis, for me, you have to take the crown off. And this is something Pete's told me before. You can't try and treat these cases leaving the prosthesis in place. You've got to get ready, take the crown off, see the implant. And I think I'd agree with Pete here. I think I've had a couple of really, really interesting and amazing results, but I've also had, in very equivalent cases, I've had very disappointed results. So it's very unpredictable. And I seem to have moved more now with the reproducibility of explantation techniques. I seem to find that removing them is a predictable way for me.
I agree with you, John.
I think the second thing to say is that just looking at some of the new surfaces that are available, I do like the MSC surface that I'm using on Southern implants, where it's a machine surface in the coronal third. And I think that that's a very interesting idea for me, that you've got the highly textured implant in the apical 2/3, and yet in the coronal third, you've got this machine surface, which potentially is less able to be contaminated to the same extent as that very textured surface. So I think that there's for me, there's also a thought with regard to using implants that have got that or perhaps tissue level, and taking the connection away from the bony level as well. So there's I think it's not just treating peri-implantitis, it's trying to kind of be ahead of it, if you see what I mean.
Treating a patient.
Yeah, exactly.
Yeah, I agree with both of you. I think if a patient, if you look at an implant and they've come in to have the bone placed around the implant, I don't think it's very predictable. No. Yes, it will in a few cases, but I can't guarantee that. And probably more than 50% of the time, it's not going to work, especially on a roughened surface when the bacteria is already there. Number of factors come into play there. The soft tissue around there, how much bone loss there is. For me, I agree with you, Dom. I think it's easy to take the implant out, either socket graft and that site and go back in and place a new implant. Whether you do a little bit of vertical augmentation at the same time, that's fine. Full arch cases, for me, I wouldn't use other implants that are around, simply because that then comes something else into the factor that they could go wrong later on. So therefore, I'd rather remove it. And even if I place it back into the same socket once it's clean, I think that's much easier to do than it is to use another implant. So yeah, I don't think it's very predictable.
Right, Stuart. Another question, and then I think we'll get on to Riz's cases, because it would be nice to share Riz's cases.
So another question. When 2 to 3 threads are found exposed on a mandibular implant, can additional Ethos be used to successfully augment the deficiency? If so, how best to clean the implant before applying the graft? I mean, this one is very closely linked to that last question we just had.
I think
the variation in 2 or 3 threads being just a little bit of implant that's exposed.
There's two sides to this. It depends if you're thinking about when you uncover the implant, if there's 2 or 3 threads not covered in bone, that's a very different scenario than you've got an implant that's become affected by peri-implantitis on a part of its circumference and you've ended up with 2 or 3 threads exposed. I think if it's an implant that just you've not achieved your full augmentation with your first Ethos, and I think if it's a clean implant surface that's been under the soft tissue, then there's nothing to stop you using a second tranche of Ethos. And that's a very predictable way to improve that situation. And I think Pete's done a really interesting case on the Ethos site recently where you've done that. Isn't that correct? Yeah, absolutely.
Yeah,
really.
And you know, it's always good to sort of show that every now and again we all have problems as well. You know, we're dealing with the human body, and a lot of things are out of our control. And the key is to try and always aim for 99% success, because whilst it's okay to have a surprise every few months, you don't want to have a surprise every week, because that's not good for an old guy like me. Riz, do you want to show your case that you were talking about now? And we'll do that, and we'll just do a couple more questions afterwards.
Okay. Right. Can you share my screen?
Yeah, it should come up, and you just go share my screen.
Okay, let me just have a look.
I saw a bit of buccal fat pad there, I think.
Oh, that's coming, don't worry.
Yeah.
Just a little.
This is the case from today, actually. So funny enough, while I was waiting for the bridge to be made, I just wanted to show this one here. So let me just. So this is the defect. This is the case that I was telling you about, where obviously there's a lot of anterior bone loss. You can see buccal bone loss. There's blowouts. There's not much bone there, and the bone isn't of great quality. So it was a tricky case, and this is where I was thinking, well, what do we do with this sort of patient? And if you look through the CT scan, you can see that even the quality of bone there's not very dense, especially around the anterior region. It was difficult to try to get some implants to be placed into that area. So that's the case that that's how we started off today. And you can see that we've got a lot of buccal bone loss. And the thing I don't like to have an unsupported prosthesis, especially around the anterior zone. No. So we wanted to find a site there. And also, if we were going to put an implant in, it was important to have bone around that implant later on. So we've placed the implants. We've placed 5 implants. 2 of them, one of them is a B18, which is a 5x10. The other, on the upper left distal side, it's a max implant. And the anteriors are the MSE surface. So that's where we've placed our implants. And this is where I think Ethos comes into its own, because especially around the upper right side, I don't want that implant to stay as it is there. I want something supported against it, which is going to help regenerate the bone. So Ethos around there, built it up, even a bit of vertical augmentation. Into the sockets, I've placed some Ethos as well. Sorry about the X-ray there, but you can see we've got a healthy band of soft tissue, good keratinized tissue. And there's the implants that we've placed today.
You must have had your ruler out. Look at them.
Sorry?
You must have had your ruler out. Very nice.
I know, my ruler out, and you can see how much I had a bucket load of Ethos as well. So
that's
looking good.
You know, when people have done that much work and a lot of full arch work, you end up looking at their cases like Costa, and it looks like it's a guided case because everything is so spot on. And I think that, you know, it's like everything in life. You know, that's why, you know, sometimes people say, oh, do you want to do this or do that? No, there's guys out there who are really good at it. And these kind of cases and zygomatics, you've got an amazing eye to, when you look at that, they look amazing. And it's like, I see that in Costa, watching him work, and he just puts things in And you look at the x-ray afterwards and you're like, how did you get, in that short period of time you put all those implants in, how did you get them so perfect? And it's experience, you know.
It's experience. That's what it's down to. So placing one implant, having maybe the drill into one site and then going to the next site and keeping it as parallel as possible. That's what I try to do as I'm placing the implants. I mean, in this case here, what I was saying about when I'm doing zygomas is that I always place Ethos around it and also into that area around the zygomatic head. So make sure that the crestal level we have a lot of bone, because that to me is very important to maintain or thicken that buccal bone. And that's obviously covered with the buccal fat pad. So we have a combination of the buccal fat pad and the Ethos there. That will give us nice soft tissue and also give us nice bony support. And the other one I wanted to show you was just one more, which is.
I was just going to say you place your zygoma towards the distal of the zygote there, so you've got room for another one if you needed to as well, haven't you?
Sorry, going back to that. Yeah, exactly. So that's the key, placing the zygoma into that area there. You can see how low that is. So therefore, we always have an upper side to work with. Now, if I go back to one of the cases that I wanted to show, when we're doing full arches, the other thing is that we always want to make sure, and I've shown this before, is that the implants are palatally placed. So regardless of, you can see this is quite a thin ridge, but we keep away from the buccal plate because even if one or two threads are shown palatally, it doesn't make a difference long term to that implant. However, placing it buccally, we'll end up with a buccal resorption of that, the buccal plate. So that's where we place it. You can see the site on the right-hand side. Now that needs to have some Ethos around it or some sort of augmentation. I like to thicken that area up. So there's the Ethos. You can see that
like
around.
An MSC service.
It is, yeah, absolutely.
That's neat.
Nice, neat and tidy, that, isn't it?
Yeah, hopefully that soft tissue with the bone underneath will be supported, and then the prosthesis on top, so you're not damaging the graft. As Don was saying, you don't want something to be moving on the actual graft itself. And you can see how far back we can go.
That's the other benefit. You've got your screw access holes on the palatal side, looking really good.
Absolutely. Yeah, absolutely.
Wow, that's a zygoma case.
That's a zygoma case.
Wow.
Lovely results.
Those screw shots are
That's sweet work.
Thank you. So I'll go back to stop sharing. Do I have to stop sharing?
Yeah, I think there you go. We'll swing it back. Yeah, and what's the next question? Orthodontically, it doesn't make any difference. Yeah, it doesn't make any difference because the material is fully turned over to bone. So this is one of the benefits here. Yeah.
You might struggle to intrude or extrude an implant, though.
Yeah.
Pull everything else around. Right. Yeah. This is often I stand accused of often never describing is when you've done something for like 20 years, the same sort of thing every day, you tend to neglect talking about the finer details. You assume everyone's just got those. I mean, it's difficult. I mix most of mine outside the syringe. We've got a new syringe coming. It's coming forever, but regulation in the EU now, Brexit, then medical director. I mean, the amount of regulatory hurdles being overcome. And now, every time we try and export to Europe, it gets put in a warehouse in Italy or somewhere for 4 or 5 weeks, because I guess they want to teach us what's the lesson believing. So it's just a question of regulatory issues. I know, but there again, I've never bothered me because I mix a lot outside the syringe. And
for me, how I do it is I tend to go 50-50 water Ethos. If I'm going for an average mix, I put an extra quarter water, so I pull the syringe back a bit further, and I don't tamp it as much. So I don't use my gauze to tamp it dry as much for a wet mix. And if I do a dry mix, what I do is I just do the 50-50 water and saline and ethos mix it thoroughly in the syringe, really making sure I'm getting all the ethos mixed, but then I tamp it much more. And then I create a very dry mix. But you have to have a strong hand then to extrude it from the syringe. So I have to use my left hand. If I try to use my right hand, because I'm left-handed, I can't do it.
Yeah.
It's embarrassing in front of the nurse.
Yeah, I tend to, when I do tend to mix it, once I've mixed it with the saline, I don't tend to look at how much saline I put in there, but then it depends on the gauze. For me, it's the pressure on the gauze and how much I need to dry. And then also, if you're doing socket preservation or you put a plate, then I can use the gauze inside the socket and just press it and dry it at the same time. So even if it is slightly wet, I wouldn't leave it wet. I can always dry it out. And I think when you're starting off with ethos and it looks like a wet mix, it doesn't matter. Just dry it a bit more. You'll just wait a while and it'll dry by itself and then put it in. So
the problem with flooding the ethos in the syringe, in other words, putting way too much saline in, is when you take it out, you're actually taking more of the calcium sulfate out rather as the beta TCP. So that can affect the setting. But having said that, it'll probably end up working just as well. So it's not a real problem, but I just wanted to bring that up to people.
No, I think also the blood, controlling the blood is very important because you could have a relatively dry mix and then placing that into an area where it's really bloody and you haven't controlled the bleeding, it's obviously going to wash away. The mix is going to change.
Totally right, Riz. I've been caught out a couple of times where you've opened your flap, you come to place your graft and you've not done your releasing incision. You go for your releasing incision and you flood your site with fresh blood and you're waiting a few minutes. And if you haven't got a clean site, some of that ethos is just being washed away.
Yeah, definitely. So firstly, self-tissue release first. I completely agree. Do your site prep or whatever you need to do once the bleeding's controlled and then carry on with your ethos.
Yeah, and don't do your periosteal release just before or just after either. So if you put a bit too much ethos in and you've realised you haven't got enough periosteal release, I think you have to take that one on the chin and you have to actually, do your periosteal release appropriately. And then you may lose a little bit of the ethos. But saying that, I do like to see a pink ethos. So when the ethos has got blood through it, I like seeing that. I don't want it to be washed away, but I want it to have that pink tinge to it. That to me is a good sign.
I've sort of shared that thought, Dom, because sometimes when you're doing surgery and you want it to look clean and you're taking a photo, you think, I want nice clean bone, which actually, from a physiological standpoint, we don't want to dry the bone out too much. But with the ethos as well, you're putting it there for a reason. You want blood infill, but when we're taking that first photo, for some reason, I want a nice, clean, white ethos. But actually, we do want it to be pink and bloody.
Yeah, really. Yeah.
Right. Should we, smoking. I see the next questions come up already.
So how does smoking influence the predictability of successful grafting with Ethos? It's like all things, isn't it? More smoking, reduced blood supply, increased risk. If you've got a deck of cards and you're just increasing the risk that you're going to have a biological issue at some point.
Yeah, and smokers are going to lie to you as well anyway. They say they're going to stop smoking for a week. And I've walked out of the practice and the guy who said he's going to stop for a week was having a ciggy in his car outside. I couldn't believe it.
Peter, I got one bed and I was doing a double arch and the patient went to the bathroom and he was outside prizing his lips open because he couldn't feel it, trying to have a cigarette. This is a double arch case.
Yeah. I think we go back to what Pete said near the very beginning of this whole thing tonight. You treat the patient. So therefore, it's not really the predictability of the ethos, it's the predictability of the patient as the host for growing new bone. So, you're giving the right fertilizer on that field by putting the ethos there. If it's poor soil because you've got a patient who's using cigarettes, that's your problem. And, basically, as Stuart said, it's, you reduced vascularization, you've increased inflammatory markers, you've all sorts of different things going on that'll affect the generalized ability for that patient to heal. So, in some of your bigger cases, such as what Riz is doing day in, day out, where you've got really big grafts and you've got really big flaps there and the whole rest of it, that's a big wound. That's a big surgical procedure. And when you start thinking, well, if you're a patient having a big surgical procedure done on their arm and then they were blowing cigarette smoke onto it 20 times a day, you wouldn't expect it to heal very well. And yet when patients are smoking after these procedures, that's what they're doing, filling the mouth with concentrated poison.
Tom, unfortunately, I don't know why, but unfortunately, they don't have the same respect for the mouth as they do for the rest of the body. And as you know, it's the same with when you talk about, I need to do a graft. It's relatively small charge on top to do a graft, and they're like, well, I'm not sure about that, and I'd find somewhere cheaper. And I said the same thing. You wouldn't have a cheap prosthetic. You wouldn't have a cheap hip, would you? You wouldn't start shopping for a cheaper titanium. But unfortunately, in the mouth, they want to do that. So if they're the kind of patients who are looking for that, really are the patients that we want to treat.
That's true.
Yeah,
that's so true.
I always knew a dentist in town I used to work who used to say, I charge the most. And the reason they did that, I'm not sure I agreed with it entirely, but they said that they self-selected patients who weren't looking for a discount. And that was, that price to the bottom scenario is a road to nowhere. So,
I agree, but then on the same respect, if you're a dentist doing it and you've quoted a patient for a graft and you have to do more grafting,
yeah,
I think it works the other way around, where dentists are like, well, I'm going to open another syringe. Well, so what?
Absolutely.
We always have to take the responsibility for success at the end. And this is the whole thing when Stuart and I were talking about it earlier on about in medicine, it would be just seen as revision. Your hip has done its 5 years, or there was a problem, we need to do some revision surgery. For us, it's deemed as failure. And I think we're digging our own grave here. So, let's see.
Yeah.
No, it's the same. It's the same with
surgical revision. Surgical revision is a much better term than implant failure, isn't it?
No, I agree. But this is when we're doing for large cases, and they say, will that be it for life? Without seeing me. They all say the same thing, will that see me out? And it's the same thing. I said, look, a hip has to be replaced after 15 years. I mean, I can't predict that these implants are going to stay for 30 years. Can't do that.
No.
Yeah. Right. Next question, Stuart.
How should I use Ethos for socket preservation? Is primary closure essential? Is there anything that can go over it and plug the gap? Now, I mean, when we take a tooth out and there's an alveolar defect, and I suppose I can put my hand up and say sometimes with the patient, I'm trying to get to the end result as quick as I can, and I might place Ethos and put a collagen sponge over the top with a little sort of X mattress horizontal suture to just keep that collagen sponge in. And I've seen some very good results from that. But Peter, with sort of a slightly old schooler, let's go for the predictable option, would say, let's take the tooth out, let the soft tissue heal over that. That gives you periosteal closure so that when you come to do a socket preservation 5 weeks after the extraction, you've got soft tissue that you can open, degranulate the site, place your Ethos, and then close over the top, which is probably the more predictable way to go. But there are other options as well.
I just want to say, in terms of socket preservation, I know a lot of people like preserving sockets. I think if you're taking a tooth out and the socket is intact and you're going to go back in and place later on, do you need to then do a socket preservation? Just let it heal naturally. You'll get very good natural bone. Unless there's a defect, unless you're worried about going back in, for example, in a sinus area where you're trying to avoid a sinus graft, then I get that. If there's teeth on either side and you're just taking the tooth out and it's a non-aesthetic zone, leave it alone, let it fill up with natural bone, and then place the implant.
You see, what I tend to do is I'll tend to place the implant. So obviously not in your circumstances, but
it's very rare socket graft. But the thing with socket grafting is that the reasons for using it is that it can be case dependent. If it's been a very infected site or certain people, you can lose dramatic dimensions. The other problem with socket grafting is everyone thinks it's easy. It's actually one of the hardest things to do. And this is the crazy thing about life, is often easy things are hard and hard things are a little easier because you've got more experience to do. But what happens in people when they pull the tooth out, the patient's gone through the trauma of having a tooth taken out. Now, they probably have a cyst or an active infection. No one's going to clean the site properly, and this is where the failure occurs. Whereas if you leave it for 3 to 4 weeks, 4 weeks, and you raise it flat, you're in a much more relaxed frame of mind. You can then clean the site properly and mainly place the implant. So it's very rare without socket graft. And that's why I think old school comes from learning a few lessons. But I'm doing a lot more immediate now and trying out a lot more things, and things are looking good.
I mean, I love the cervical system you're using. I've got to try it myself. I mean, I'm loading a lot at the same time as placing immediates, but the cervical system seems to be a very nice way to both place your immediate implant, create an ideal emergence, but at the same time protect your graft around the implant. So, you know me, I'm a bit dodgy with regard to doing a lot of cases where I've left exposed ethos, and I've done that for years. And that's really down to two things. It's one is that I feel that ethos is a bacteriostatic material, and so the likelihood of a post-operative infection is very low. And secondly, I feel it encourages epithelialization from the edges of the socket, so you get fast epithelialization over the ethos anyway. But I think it's an outlier technique, and I've said this many times before. I think it's something that works predictably for me, not every time, but most of the time. But what I would say is it's not something that I would be doing if I was a beginner with ethos. Perhaps.
I think, a lot of things come in there. One is to socket preserve, you're right. Degranulation bursts for me, are the key. You have to clean that site out. If you're going to socket preserve, that's fine. The other thing is doing immediate extraction placements, which is, I think, a lot of us are doing on single teeth. I don't see why, and that's very predictable. Taking the tooth out, replacing an implant, whether you place a crown on top or not, that's entirely up to you. That's another skill set. But even just putting a healing abutment on there, I think is very predictable. Peter, you've shown cases where you've had ethos and the implant's just been placed directly into the ethos, just pushed into it, and that heals very well. But it's just taking your skills to the next level, however, not pushing the boundaries. I think if you have a site where you're taking the tooth out and the bone is healthy, then what's the point of preserving the bone there? You might as well just go and place the implant and put the ethos around it.
Yeah. As I say, I think what I had a lesson from was the early days of immediates, where we were using much wider implants and big taper implants, and all we were doing was basically leaving no buccal bone, and then they all didn't look so good in 3 or 4 years' time. But I think we've learned a lot about immediates and about temporization, and placing your implants more playfully. These are all things we've learned. Let's move on to the next one, Stuart. I think, what is it?
Do you recommend covering the surgical site with a periodontal dressing, such as Copac, or even suturing something like Aurade to prevent the washout of the ethos? I mean, I think both of these things, if you've got them, will help. As Dom was saying earlier, if you're putting ethos in and you're leaving it for secondary intention, you need to make an estimation on how big is the site, how much you're leaving uncovered. If it's too much, then should you be doing it a little bit old school like Peter and sort of leaving it, or more predictable, letting things heal over? But I mean, an Aurade or a bit of Copac isn't going to do any harm.
Yeah, you've got to suture the Aurade, otherwise the patients just pull them out in a few minutes. Right, these are live questions here. Titanium mesh, yes, I've been seeing a lot of really interesting things, and I've got some right here, and we've got a couple of cases planned. So I've done one. I think this is an important area, and it does seem to work very well with titanium mesh. We do some big cases with another friend with CAD-CAM made titanium meshes. So I think this is a really exciting area, which I must work more in myself as well. I feel like I need to do more. How do you guys feel about that?
It's not something I use a lot of, titanium reinforced membranes. So it's not my key area of expertise. So I won't. I'm not going to say much.
I've used titanium reinforced membranes when I was doing big grafts. I used to do a lot of the urban technique, the sausage technique with the graft. The problem is that using any sort of non-resorbable membrane, if it becomes exposed, the case goes wrong very quickly. And it's predictable to a certain degree, so you have to be very meticulous with your soft tissue release. You have to make sure that the suturing is very good and on point. However, even with that, I think even just a corner becomes exposed, you lose the graft. So you have to be very, very careful. So I just think it just comes with a word of warning there, just to be careful there.
And as they say, you've got to use the tongue scraper. No, only kidding. I'll joke that. Anyway, where do you stand? Vitamin D. Whoa, this is big thing on today, isn't it, Dom? I mean, I couldn't believe that case you were talking about. I mean, I've never had that happen. I mean, that must have been traumatic.
Well, this is a chap I was mentoring. He's one of the most pleasant guys you'll ever meet, and he's got a good set of hands, and he knows what he's doing. And we watched this case. I mentored this case for him, and he was meticulous with his surgery. And over 2 different surgical sessions, every single implant failed. And yet this chap has got vitamin D, that's within the normal range and slightly towards the high level of the normal range. So it's not vitamin D with him. And we're starting to think, is it something very unusual, such as titanium hypersensitivity, something like that? It's very unusual. But going back to vitamin D, I think the things to be aware of is it's very hard to overdose with vitamin D, believe it or not. So, and it's surprising how many people are either deficient or insufficient of vitamin D. And I think the third thing to be aware of is it's not impossible to get tested. So it's quite easy to actually get a test and find out where you are within the range prior to having implant treatment done. I think if you're going to supplement with it, I think it's important to take it with vitamin K. So I don't think you should just take it on its own. I think you should take vitamin D with vitamin K too. And I think that's important because that allows absorption of the vitamin D, and it's important in the way that it works. So I think that, it brings up very interesting points. I think one of them is the whole aspect of pre-screening our patients prior to treatment, and what level of pre-screening should we do? Should the test for the vitamin D level be part of our pre-screening process for all patients? The amount of middle-aged patients, particularly women, who've been using sunscreen for many years and covering up in the sun, and surprising numbers of them that are actually deficient with vitamin D. It's a very interesting topic in general.
Yeah, Riz, I would have thought that's something really big with full arch cases. Is this part of your regime, your pre-treatment regime?
In certain clinics, yes, they do test it. Not all the clinics, and not all the time we've insisted on it. Generally, I haven't found that to be a problem, to be honest with you, in full arch cases. However, I know there's a lot more talk about it. And some people just recommend their patients start on vitamin D just as a normal vitamin take, running up to the treatment. I think that's quite sensible as well. But I haven't really looked too much into it.
As Dom just said, it's very difficult to overdose on vitamin D. It's probably one of those good ones that's just there to recommend. I mean, we when I was working at Evo, we used to take bloods for everybody that came in. But we were taking a full set of bloods, and we then had all this huge data set for all these patients that we were then returning to their GPs And the GPs eventually sort of pulled us up on what was essentially a data dump, in which we were giving them a lot of information that they then had to act on sometimes that they weren't always appreciating. So the question is sort of, where do we draw the line with these sort of pre-screening tools, and how far do we go?
Well, that's I was just going to say that's like the incidental OMA, which is the incidental finding. I know when I had my accident, I had a full body CT done, and they look for it. It's surprising how often in these things they find things that they weren't expecting, like nodules on your liver and things like that. They didn't in me, but you've got to look at what's the benefit and deficit of these things. And as Stuart just said, these full blood screens, you are actually, in some cases, highlighting issues that the patient had never been aware of and would have never affected the patient in their whole life. But now they are aware of it, and sometimes they're worried about it, and sometimes, so it's a balancing act, without a doubt.
Let's get on with the questions because we're nearly out of time. We've got a few more minutes. The next question is the loss of buccal place, the adjacent teeth. What do you do? Can you regrow the PDL? This is a really big question, and we could spend a whole day talking about it, and there's no scientific evidence. So it's a very difficult area. It's a lot of hearsay. Personally, I don't overclean the tooth surface because, like Howie Gluckman, I believe that there could be progenitor cells for PDL there. And I do think the PDL does seem to heal itself. I've got 10-year follow-up and with distinctive plates visible on X-ray. It's a very difficult area. There's no real research. It's hard to do research. And so that's what I do is I try not to disturb it as much as I just clean any granulation away. And that, you guys, anything?
I think you're the guy who's been doing the most of this that I'm aware of, Pete, with regard to Ethos. And I've seen some of your cases,
Subcrestal placement, again, it's down to the implant design and the implant system. You look at Andrew, Dom, he loves his tissue level, whatever brand, it's tissue level, and we're going to do a talk on that. And, he gets amazing results. And again, it just varies so much from case to case, from what system you like, the way you actually train yourself, and the way you seeing that, this job's a very lonely job. We often making decisions by ourselves at the time, even when Riz has got a team around you, you're the guys making the decisions. And you often have to make that decision yourself. And so it's quite, difficult to really answer that. So place the level to the system you're using, I think.
Just one thing I would say, Peter, is that when you're placing the implant, when you're talking about subcrestal, if you're going to augment, the problem is if, for example, you have palatal bone and the buccal bone's gone, a lot of people, I've seen cases where they've placed the implant so far subcrestal, where they're trying to chase the buccal bone, as opposed to placing it in the right place and then augmenting onto that site. And that there's a difference in the two. So for me, I always want the implant placed in the right place and then augment onto that.
Yeah, it was like the case I showed. Theoretically, that implant's meant to be placed 2 millimeters subcrestally, but I was actually placing it 5 millimeters supercrestally because I needed to regenerate vertically. And this is the real, there's no single answer for this. This is one of those things that it varies from case to case, system to system.
I think we've all placed too deep on occasion. I know I have.
Yeah, I know. I got accused of, as I said, I got accused of that on a few cases, placed it too deep. And that's so not me, but it's just the way it turned out. Somehow we got too much vertical growth.
As long as you go over the ID nerve, you're probably all right most of the time.
Yeah. Anyway, PRP, I didn't really know that people were using PRP anymore. I still remember a couple of bag guys who travel around doing implants, dragging their PRP machines around, and years later asked them,
"What in the car?"
Yeah, was that worth it? And they all go, "No." So, but PRF is a very interesting area, and I think there's a lot of sense. Somehow, I feel that there might be a slightly contradictory thing in healing and ethos and PRF, but I don't want to go too much into that.
I don't think you should make it.
Yeah. Stopping the bleeding. Look,
I think that comes down to site preparation, doesn't it? And what we were saying earlier about your
if the worst comes to worst, just get your nurse to put a dry sterile gauze over the graft, even if it's bleeding. And actually, you stand up for a full 5 minutes, go and, make a cup of tea or stretch your legs somewhere or go outside and have a fag. And you'll be surprised it does, it stabilizes and it's all right. Wow, we got some more questions popping up. What for immediate early placement are you irrigating the socket site prior to, after, with any liquids? Just saline, really.
Just saline.
Yeah, I have used Blue M in a site afterwards to try and help. But, again, that's anecdotal, so I'm not.
I know some people use peroxide as a wash. 3% peroxide, just give it a wash out and then degranulate and then place the implant and the ethos.
Yeah.
I tend to find those degran burrs are pretty good at getting everything out.
Yeah, I just did a failed implant on a friend. A failed implant is someone else's implant. That's obviously describing them. Your own implants, let's see what we can do about it. But this one went from no bone loss, 10 years, really nice tissue level, to absolutely nothing holding it in and suppurating in about a month. I couldn't believe how quickly it went off. But that's life. Anyway, let's look at a single implant case. At what point do you decide buccal plate too thin to preserve? It's something that you just do.
I think it's when you look at that buccal plate and you think there's no way there's any endosteum in that whatsoever. It's just a piece of cortex. If you can see through it, remove it. If it's really wafer thin, it's there for nothing. Get rid of it.
Yeah.
But if it's fairly thick and juicy and it looks like it's got vascularity, leave it. But it's a real judgment call on an individual case, and occasionally you'll end up being bitten by that. I think it's an experience thing. I don't think you can give a rule on this.
Yeah, I think for me, for full arch cases, when I'm placing implants and it's a thin ridge and the bone is just creaking buckly, I'd rather remove it and graft onto it because I know I can get on my.
What you just said, creaky. So if you can push it and it moves. Do you know what I mean by that?
Yeah, that's exactly when it's expanding when you're placing the implant. And exactly, get rid of it. Totally.
That's another thing is sometimes when you've got thin bits of bone, I've had cases with sequestration, and boy, does that cause an infection.
Yeah.
But I think overall, I think we should end off now anyway. Because it's come to the end of the site, and
I'm just charging my battery's running out as well. So.
Right, no problem. No, but thank you everyone, and it's always such a good time just to sort of chat, and this is the new normal. Unfortunately, is instead of chatting in the pub or at the conference, we're all just chatting over webinars. And it's great to see faces again and have a chat because we miss these chats and time. But thank you, everyone, and thanks, Stuart, Dom, Riz, and all the delegates. It's been fun, and I think hopefully we've imparted some information, some ideas from our humble means. If there's any other questions, just contact Ethos and we'll hopefully be able to get to answer them. Thank you very much and have a good evening. Thank you, guys.
Take care.
Thanks very much.
Bye.
Cheers. Bye-bye.
You guys.